All right, good morning, good afternoon, or good evening, depending on where you're watching from at the moment. It happens to be morning here in California where I am. So I'm going to say good morning and say my name is Darren Salmi, and I'm a pathologist here at Stanford University School of Medicine. And I'm guessing you don't get a lot of pathologists at these webinars. So I am very honored this morning to have the chance to talk to you today, at least in part to let you know that we pathologists exist, and hopefully to give you an idea of how we are working behind the scenes to help you and your patients, even if you've never met one of us in person. And I say part of the reason I'm here is to basically say that we pathologists exist is because the other part of the reason I'm here is to extol the virtues of the placenta to an audience that I think can truly appreciate this very underrated structure. So I'm going to go ahead and get my screen going real quick, and then I'm going to talk a little bit about the placenta, and we're going to have some panelists at the end for a discussion that hopefully we can talk about and expand on some of the stuff we talk about in this presentation. So let's go ahead and get going. So what is it that a pathologist can actually contribute to in terms of your knowledge, especially when we're talking about the placenta? Well, first, we're going to talk about the sort of hidden role pathologists play in perinatal morbidity and mortality. And then we'll specifically look at what the placenta can tell us in cases of intrauterine fetal demise, or IUFD. And at the risk of losing your attention completely, I'm going to show some microscopic images, the sort of things we see under the microscope in pathology, as we go over sort of the four major categories of placental pathology. And along the way, hope to confirm your existing belief that the placenta is incredibly important. So just a quick background on pathologists. What is that as a specialty of medicine? Well, it's actually a very large specialty, even if you don't interact with it directly very often. And so we actually divide the specialty into two. We have what's called AP and CP. AP is for the anatomic pathology. And the anatomic pathologists, we're the ones who do things like gross and microscopic examination of tissues. That could be anything, and more commonly, it's, for example, biopsies in suspected cases of cancer, but in the perinatal world, it would be something like a placenta. AP is also where we have autopsy, and autopsy could be in the medico-legal or forensic world, or it could be in the hospital-based world, and it adult or pediatric, but in this particular case, this where a stillbirth or a neonatal death would fall under. There's also another half of pathology that's called CP, or clinical pathology. And clinical pathology is sort of the black box where you submit a specimen and you get an answer. Well, that's all of the tests that basically any lab does is through clinical pathology. And they're clinical pathologists, along with an army of lab techs, that are providing those answers to millions of tests a year. And in the perinatal world, especially, that would include things like cytogenetic studies or exome sequencing, basic blood cultures in cases of sepsis or chorioamnionitis. Literally any lab test is in some way going to go through CP, or clinical pathology. So that's what pathology is in a nutshell. And I am in particular a pathologist on the AP side, or an anatomic pathologist. So I do gross and microscopic examinations, and I also do autopsies. And so with that in mind, I think we're going to delve specifically, especially when we're talking about nursing and nurse midwives, how do we approach in the pathology world IUFD, or intrauterine fetal demise? And what are the sort of steps we take and the answers we can and can't provide? So some cases of IUFD, at least in our institution, may be predicted. So whether it's by ultrasound or other forms of prenatal testing, IUFD, we may see that coming ahead of time. On the other hand, many still do occur unexpectedly, and it raises the very real question of what caused the stillbirth. And for the families, that raises questions of, closure. Why was stillbirth occurring in this pregnancy? But also, are there things that I should know about that might guide risk for future pregnancies? And there have been many large studies over the years that have looked at IUFDs and tried to categorize them. And I think it's actually been a very helpful effort. And as I go through the next few slides, I think you'll understand why these large studies have been so helpful for us in the pathology world. And that's because when it comes to IUFD, at least in our world, the non-medical legal autopsies or non-forensic autopsies, which is what we would say like anything that's a natural death, so anything that's not an accident or suicide or homicide, those are the three, legal autopsies. They're only performed if the family gives consent. So they're really a service that's really up to them. If they want one, we do one. If they don't want one, they don't. And it's really not up to us. It's not up to the clinical team. It's literally all up to the family. And I think at the end, our panel discussion and our panelists especially are going to speak to issues that arise in IUFD and discussions and situations that may lead people to want or not want an autopsy in such situations. But the good news from our perspective is, in most situations, an autopsy might not be necessary to find the answers that the family needs. And why do I say that? Well, thanks to these very large studies that have been done over the years, we can find basically the categories that are roughly reproducible in terms of what percent of IUFD are caused by certain etiologies. And the first thing that's important to look at is, and it's called different things here in different studies, but in this study here on the left, it's called malformation, and this study on the right, fetal genetics / structural. So they carry slightly different names, but the key word is, I think, fetal. A fetal etiology, anatomic, structural, intrinsically genetic to the fetus, some sort of anatomic malformation or anomaly. Now, in those situations, which as you can see here, that's about 8.3% and 13.7%, that's where I think a lot of people tend to think in cases of IUFD or even a neonatal death that an autopsy per se is what's needed to help find the answers. And I think that's a reasonable conclusion to draw in these situations because they are structural. And so those would be examples where postmortem imaging might show evidence of a skeletal dysplasia, such as an absent radius here, or a congenital cardiac anomaly. And my subspecialty happens to be pediatric cardiac development and pediatric cardiovascular pathology. And you can find, subtle details in the location and nature of VSDs or other maybe microscopic problems of the conduction system. And so I think the issue is a lot of times is people think that that's going to be the majority of etiologies for IUFD or neonatal deaths. But if we go back to this chart, again, it's really a fairly small percentage, about 8.3 and 13.7%. And the even better news when we try to stratify things is if there's prenatal imaging, there's usually a clue because it's a structural or anatomic thing that you can find on imaging. Even if it's maybe not well delineated, they say, gosh, there's something we see in the heart. We're not sure what it is, but we sense from our imaging or other prenatal tests that there's a cardiac anomaly. It's somewhat at least detected and known ahead of time. And if we take those out, what we find is actually 90% of cases are answered by the placenta. And you might see, just if you're really paying attention, something here that says fetal causes. Yes, so the word fetal is in that category as well, but we'll see that that is a different type of fetal cause. That's a fetal cause that can still be answered by the placenta. And so that's why, and hopefully the panelists who know much more about this than I do about the discussions about how can we find answers, this I think is the silver lining, is that 90% of the time, an autopsy may not be needed at all, but the placenta becomes crucial. And unfortunately, historically, the placenta has been very understudied. And to be honest, it's really only in the past few decades that the function of the placenta has become better understood. And simultaneous with that, the pathology has become more clearly understood. And we've gained a lot of knowledge in, maternal versus placental versus fetal conditions that can be seen in the placenta. Although, to be fair, because it's been historically understudied, there are still a lot of conditions that are well described and well characterized, and we know their consequences, but the etiology still truly remains a mystery. But what we can do when it comes to placenta is basically put it down into one of four categories that we're going to talk about. Acute chorioamnionitis, probably the one you're most familiar with and see the most. Villitis, specifically we're going to talk about what do we mean by VUE, or Villitis of unknown etiology. I mean, there's an example right there where we don't know everything yet. A broad category of maternal vascular malperfusion or underperfusion. It goes by several names. And then finally, fetal vascular malperfusion. So again, even though it's a fetal thing, we can find it in the placenta. And we'll start with, again, probably the most common one, acute chorioamnionitis, with a little bit of a refresher on the fetal membranes. Did just finish, actually, we finished our med student and PA students, just finished their fall quarter. They just had their embryology exam, which I teach, and they just had these slides on Monday. They just had their final. So this is all a refresher for me as well. But the fetal membranes, going all the way back to early development, are formed by the union of amnion and chorion layers, hence the other term for the membranes, the chorioamniotic membranes. And those are the ones that you can basically pull apart very gently when you're examining the placenta, the amnion being the much thinner, more delicate inner layer, and the chorion being the somewhat thicker outer layer. And that's also what gives the chorionic plate surface that shiny look, whereas the basal surface that was attached directly to the uterine wall has that much more rougher look to it. And in severe cases of chorioamnionitis, a gross examination will right away give you that appearance of very cloudy membranes as opposed to these very translucent membranes. And so in certain cases, it can be detected even before the placenta reaches the pathologist. And even more so, the clinical symptoms can sometimes be present that alert you to it even before delivery. Of course, fever and various ways of documenting, at least at our institution, one, very high fever, two, lower fevers, elevated maternal white cell count, and a lot of criteria that our OB teams here use to be very diligent about basically screening for chorioamnionitis. But even then, sometimes it can be clinically silent. And so we will always examine the membranes the same way, regardless of whether or not there was suspicion of chorioamnionitis for that reason. Now, what we'll see when we look under the microscope, especially when we're looking at the fetal membranes, would be the presence or absence of inflammation. And when you see our reports, you'll see both a stage and a grade. So the stage being location of the inflammation, how far has it gone, the grade being the severity. So you usually see two numbers, a stage and a grade. And you'll also see two things. You'll see a maternal versus a fetal inflammatory response. So when we're looking at the membranes, we're actually looking at the maternal response. So the maternal response actually happens first. And that's because there are maternal-derived vessels in basically the decidua or the decidualized endometrium that's caught up in the membranes that are continuous with the maternal supply. Hence, this examination actually reflects what we call maternal inflammatory response. It's the first response that happens. Usually from ascending polymicrobial type infections, but occasionally hematogenously, and that's usually more from, at least in our area, like outbreaks of listeria from contaminated vegetables or dairy or something like that. But regardless of the etiology, what we're looking for is where is the inflammation in these membranes? And just to orient you, because I'm sure you don't look at a lot of fetal membranes under the microscope, this layer here with these cells up top, that's the amnion layer up here. It's very thin and delicate, and it's fused with the chorion layer a little bit deeper that eventually attaches to the decidua, or what's left of the decidualized endometrium. And essentially, in a nutshell, what we're looking for is, where do we see the inflammation? And that's all of these tiny blue dots here. And then here, when there's a lot of them, here where there's a lot of them, and here they're all the way through. So we're essentially looking, well, are they going from the chorion up into the amnion? So here they're staying pretty far down, and that's a lower stage. Here we see them in the same place, but now they're working their way up into that pink area towards the surface. So that would be a higher stage. And then finally here, we see these blue purple dots going all the way through and basically reaching that superficial most layer of the amnion. And that would be as far as it can go. So we would have these different stages along with different grades of severity. And so that's what we look at when we're looking in the maternal response, and that's going to be in the membranes. But it's actually very important to look for what's called a fetal inflammatory response. And that's actually going to be seen more in the vessels, either the chorionic plate vessels or the umbilical vessels. So we always examine those as well. And in the case of fetal inflammatory response, we're again looking for those tiny blue dots. We're looking for the location and extent or severity for stage and grade of the inflammatory cells. And we're looking at where they're located. Is it just in the umbilical vein? Are they also in the umbilical arteries? And that's helping us determine if it's a higher or lower stage. And this is particularly important when you read a report and you see maternal versus fetal, because the fetal response, a presence of a fetal response, if it's anything more than stage 0, grade 0, that's actually going to become associated more with a greater risk of neonatal sepsis and poor neonatal outcomes. So the presence of a fetal inflammatory response is going to be particularly concerning. Moving on to the Villitis, especially Villitis of unknown etiology, because I feel that's an enigmatic term we throw around sometimes. But Villitis in general, just to get back to the core concepts of what is a villus in its basic sense, well, the placental disc, even though we can't see it microscopically, is essentially made up of villi surrounded by the intervillous space, which is just the maternal blood. And so we have our fetal-derived capillaries sitting inside all of these villi. And here's a microscopic image on very high power showing the very amazing, what we call placental membrane, essentially the equivalent of the alveolar membrane of the lungs, except here we have fetal vessels with fetal red blood cells, a very thin, what we call trophoblast layer, and then the intervillous space that has maternal blood. So it's basically identical to a lung capillary and a very thin layer of pneumocyte epithelium in the lung, and then air, but except in the placenta, instead of air, we have maternal blood. And so this is essentially all of what the placenta comes down to, is this very thin, essentially placental membrane of each of these individual villi. Now, when we look at the placental disc and we're looking at the villi, we're looking to see if there's inflammatory cells. So over here on this side, there aren't inflammatory cells. It's just a very thin membrane and a lot of fetal capillaries with red blood cells, which is just what we want. Over here, we see a bunch of extra blue dots, and those extra blue dots are inflammatory cells. And in that case, we have Villitis. And Villitis comes in a couple categories. I'm going to talk about chronic and VUE in a second, but just to acknowledge that there is acute. And when you see acute versus chronic in our reports, what that really means is what type of inflammatory cell we see. So in this case, these blue dots are neutrophils. And so this is what we would call acute inflammation or acute infectious Villitis, because we also see infectious organisms. So this hazy purple that's kind of not as well defined as these cells over here, these happen to be clusters of group B strep. So these are what bacteria look like under our regular histologic imaging. Now, we could also do gram stains and confirm that it's group B strep, but this is a classic appearance of an acute infectious Villitis. And Again, the common organisms are the ones that I'm sure you're more than familiar with: Listeria, Group B strep, as I just mentioned, E. coli. Now, when we see different types of inflammatory cells like we do here, these are what we would say mononuclear inflammatory cells. They could be macrophages, plasma cells, lymphocytes. So when we say chronic, we talk about those types of cells. And specifically what we see in this one, these inflammatory cells are plasma cells, and they're typically a sign that there's congenital syphilis. And so chronic infectious Villitis are usually going to be associated with those torch organisms. Very commonly, we see them in syphilis in CMV or cytomegalovirus. And in those cases, especially for cytomegalovirus, we might be able to see, if we look at enough villi, strange little appearances in the cells that when we look on high power, I know it's very blurry here, we can see this, and even without our special immunohistochemical stains, we can recognize these as what are called owl's eye nuclear inclusions. And so sometimes before we do any special studies, if our regular placental examination, we see these, we can say, hey, we think that there's a very high chance that there is CMV or cytomegalovirus infection. Very timely and very new over the past couple of years is when we see inflammation now sort of between the villi, and that would be intervillitis or intervillositis. And now when we see something like that, this was really triggering an immunohistochemical stain for SARS-CoV-2. So this would be what a COVID placentitis or COVID intervillositis would look like. And it would trigger us to do the immunohistochemical stains to confirm that there's a presence of SARS-CoV-2 virus in the placenta. And so that's all the different types of things we are able to detect when we're looking at chronic inflammation or chronic Villitis. But unfortunately, there is this entity that you will see in reports that's called Villitis of unknown etiology, or VUE. And it's one of those situations where we can recognize it because we have gross findings of little pale spots. We have histologic findings of chronic inflammation, just like we do in the other forms, but without an organism. And we know what it's associated with. We know it's associated with fetal growth restriction. We know it's associated with prematurity. We know it's associated with stillbirth, especially with recurrent disease. Yet we don't know the etiology, hence the term. Now, it's been shown that these cells are, thought to be maternal T cells, that may be an immune-mediated disease, but we're far from truly knowing the actual, true etiology, so we still have this term. But we do know, again, things that are associated with it, and the fact that stillbirth risk is increased with recurrent disease. And it's a great example of where continued studies will hopefully give us more answers than we even currently have with VUE. The next category is a very broad category: maternal vascular malperfusion or underperfusion, uteroplacental insufficiency. Your institutions might use even different terms than that. But one thing that I think is important to keep in mind is what the trophoblasts are doing in the very beginning that lead to underperfusion. So I like this little video because this is showing a blastocyst implanting into the uterine wall, into the endometrium. And we have the inner cytotrophoblast and the outer syncytiotrophoblast. And what's happening is that inner cytotrophoblast is secreting enzymes. That's what these blue blobs are representing. And these proteolytic enzymes are actually literally breaking down the surrounding endometrial tissue so that the syncytiotrophoblast can go and extend its little projections and take hold or implant. And they're also eroding all of these endometrial vessels. So all of these, red and blue arteries and veins here, they're eroding into them to collect pools of maternal blood called lacunae that are eventually going to form our intervillous space that has all of our maternal blood in it. And as a part of this early remodeling, it has to change the very nature of the blood vessels, right? So arteries have smooth muscle that can make them, constrict or relax, changes the shape of their lumen. Normally, that's a great thing, but not in the placenta. You want uninterrupted blood supply, right? So what the trophoblasts are doing are trying to degrade and remodel these vessels so that they could be constantly flowing. And, you're very familiar with preeclampsia, which is very well understood in terms of clinical significance. But one of the things that, trying to explain, like, what's the true etiology? Where is this all coming from? At least in terms of placenta and histology, one of the things we notice is that adaptation of the maternal vessels is incomplete. And because it's incomplete, you don't have quite that, like, uninterrupted blood supply, and you get, essentially local hypoxia, and that's largely the triggers for the things that clinically, like hypertension, proteinuria, et cetera. That's thought to be like one of the important drivers in this very complicated enigmatic pathology. And it speaks to the larger category of uteroplacental insufficiency. And again, it has numerous synonyms: underperfusion, malperfusion, but that's what we're really getting at, is that process we just looked at is insufficient or incomplete. It's not completely adapted for pregnancy. And because it happens early in pregnancy, and it also has a very high recurrence in subsequent pregnancy, it's something we're always looking for. And again, it's in that implantation, remodeling of spiral artery phase where things are incomplete. And it could be very heterogeneous, with areas of underperfusion alternating with areas of very high perfusion. And it isn't something that we fully know yet. It still is being studied. There are many etiologies that can be associated with this insufficiency: diabetes, chronic maternal hypertension, smoking, certain types of drug use, which go with more sympathomimetic type responses like cocaine or methamphetamines. And when we look at the microscope, we can kind of get with the severity of how it will relate to the spectrum of clinical disease, because it could be anywhere from just some mild growth restriction all the way to preeclampsia, all the way to stillbirth. So it's a wide spectrum of phenotypes when it talks about insufficiency. So what are the sort of things we might see or you might read about in a report? Well, sometimes grossly we can already pick up on it if it's pretty severe. So here's a cross section of placenta. Usually the placenta is fixed in formalin, then sectioned, and then examined, and then that way targeted areas can be sampled for microscopy. But here it's clear right away with this very pale area attached to the maternal floor. So that's the maternal floor side. This is the chorionic plate vessels here, that there was an infarction. And histologically, we would see very clearly the area of infarct or dead tissue adjacent next to some viable placenta. And so, especially if you see a small for gestational age placenta with an infarction or a hematoma, that's really going to raise our concern for uteroplacental insufficiency. And when we dig down deeply and we really look at the maternal derived vessels in the decidua, because again, that's where we're really finding this issue, we'll see areas where this is a vessel wall that doesn't actually look like, well, here's kind of a more normal looking one. There's no cells in it. It's all pink here. And that's because essentially it's died. It's had something called fibrinoid necrosis. The wall is still necrotic. It hasn't really been remodeled into a wall. And then we also see, when we look at these villi, the blue dots around the periphery are nuclei, and those are nuclei of something called the syncytiotrophoblasts layer. And it's something called accelerated maturation, where we see what we call syncytial knots, or a lot of extra blue bags, like these bags of blue dots of nuclei. And that's our sign of, again, what we call increased syncytial knots. They're not really knots, they're just more clusters of nuclei. And we call that accelerated maturation. These are all signs that we have uteroplacental underperfusion or malperfusion. Then the last major category would fall under fetal vascular malperfusion. And that's where we turn our attention back to the umbilical cord, because the decidua is where we find maternal associated vessels, but the umbilical cord is carrying blood that's continuous with the fetal circulation. And of course, we have the two arteries, the one vein. On cross-section, we always will cross-section the umbilical cord, and we'll always look to see the presence of two arteries, one vein. Sometimes we'll have little remnants of ducts that were embryologic remnants. And we'll always look to see how much Wharton jelly there is. We'll always look to see if there's any peripheral, what we say, funicitis, or any infection along the periphery of it. But otherwise, we hope to find something that looks like basically a happy face here with the two arteries and a vein, and hopefully just blood that doesn't look like it had ever clotted inside of the umbilical cord. Otherwise, when we see something that looks like this with these chorionic plate vessels that have these thrombi inside of them, and then histologically we see this is basically clotted blood inside of them, then we have FTV, or fetal thrombotic vasculopathy. And that's just what it sounds like. That's thrombosis of fetal vessels or fetal derived vessels. So this is, again, on the other side of the disc or in the umbilical cord from the maternal ones for maternal underperfusion. And of course, the problem is going to be that it's going to be fibrosis of downstream villi because they'll be starved of oxygen. And roughly when you get to about 30% of avascular villi, or villi that no longer have blood flowing through them, that's going to imply like, okay, there's a very increased risk of neurologic injury, growth restriction, oligo, or systemic thrombosis in the fetus itself. And again, it's one of those things where we can't drill down exactly the etiology, but we do know it's associated with maternal diabetes and other hypercoagulable disorders, sometimes with certain perinatal liver diseases. The etiology is, again, sort of like a lot of things, still either broad, or we're still working on ways to narrow down which etiology it is based off of our findings. And hopefully that would be something we can one day solve. But for now, what we notice is when we look at these villi over here that are nice and healthy, we see capillaries with these red dots that are red blood cells. That's what you need, right? We need fetal blood getting down here so it can have gas exchange with maternal blood in the intervillous space. Downstream of thrombotic vessels, there's nothing in here. It's just solid pink. It's just fibrosis. There's no blood vessels like we see over here. And so they're not participating in gas exchange with these maternal blood cells in between. So I think I'm making good time here to wrap up. So the take-home points I want to just kind of leave you with before we get to the panelists is that even if you never meet one, I assure you that there's a pathologist out there to help you, whether it's in the labs, in anatomic pathology, looking at a placenta for you, they're out there. And I really think, and this is something that I hope we can get the word out with, is, most of the time, 90%, the placenta itself is going to be your best chance of finding an etiology for an IUFD, regardless of whether or not the family desires a concurrent autopsy. And a lot of the time, it's superfluous and it's not even needed. And of course, we can't answer every question in a placental examination. We can't, we're still learning. There's still a lot to be learned by the placenta, but when it does, those are the four main categories. So when you see reports, hopefully you can kind of make that connection between sort of our verbiage and what it actually means. And then because it is, what is today, December, well, we're mid-December, so some Christmas gift ideas for the true placenta fans out there. You have umbilical cord chargers. You also have what I have, which my embryology students have given me over the years, these nice placenta plushies. And so hopefully those would make some nice stocking stuffers for the placenta fans in your life. And here are just some very festive looking villi that happen to be in the shape of gingerbread cookie and some reindeers. And so around December, you start to notice these shapes in the villi. You start to notice Christmassy shapes in villi. But thank you so much for having a pathologist come and have the opportunity to talk to you. And I look forward to any questions you have and learning from things that the panelists may have to share from their perspectives about placentas and IUFDs. So I think I get the ball rolling maybe, and as I don't know if questions are coming in, or I guess we'll wait for questions to come in the meantime. I guess a question I would love to have, and I guess we'll let Gila and Olivia introduce themselves, but we're joined by two actual experts who can hopefully speak. I think from my perspective as a pathologist, things I would love to hear from you are, so I'll just say there's a couple of things that happen in my practice where I would love to know what your thoughts are. Is, sometimes, there's a lot of reasons people don't want to get autopsies, and in hospital autopsies, they don't have to get anything they don't want. This isn't a medical legal autopsy. And, I feel like a lot of times, people who may not know how to get the answers, they might be approaching the family saying like, oh, like this would be really good to know for future pregnancies, you really should. And I feel like maybe there's some subtle arm twisting and pressure that isn't necessary, because the placenta can be sent, and the threshold for sending a placenta for a family, well, it's almost not even thought of. It's a surgical specimen. It's not an autopsy. And 90% of the time, we need the placenta, and we don't even need to do an autopsy. And conversely, on occasion, we'll get outside autopsies sent to us where they say like, oh, we don't know why this is, so we got an autopsy and we're sending it to you because you're the experts. And we'll say, okay, but where's the placenta? And they're like, well, we're going to send you the fetal remains. And we're like, but this isn't going to tell us the answer. We need to know the placenta. And they're like, oh, we don't have the placenta anymore. We didn't know it was important. And so I think it's important for a lot of reasons to know it on both sides, both for the family knowing they don't need an autopsy, but also making sure people know, like, send the placenta. Don't just discard the placenta if there's any question that the kid may be sick, or if there was a loss. Always treasure that placenta. So I don't know if so I see Gila's nodding enthusiastically, so I guess we'll let Gila go first, and then maybe Olivia can jump in.
Gila always nods enthusiastically. I need to say that thank you so much. That was one of the most educational webinars I've ever had the honor of attending, and I learned so much in that half hour that I never even thought of. I mean, Wharton's jelly, the significance of the thickness of the Wharton's jelly. Sometimes I see cords that's really, really thick, and I've always wondered, what is the significance of that? And I look forward to webinar number 2, which I will be joining to hear more, because I feel like you just skimmed the surface of what is placental pathology. And so thank you so much. That was super eye-opening. I am a certified nurse midwife with a master's in women's health, and I am an expert in clinical infectious disease prevention. I did a lot of research in the COVID-19 days, published some stuff and vaccine and placenta and things like that. And I'm also on the board of directors of the Israel Midwives Association as the media and international liaison affairs. So that's me. And I think that one of the things that Darren was saying, which is really important, especially working in an environment like Israel, where we have 3 major religions, which is Muslim, Jews, and Christians, there are a lot of issues with regards to autopsies. Now, I will mention that the placenta in Judaism is also considered a body part, which means it's required to be buried. And sometimes convincing the families to send the placenta isn't easy, but it's definitely easier than convincing for an autopsy. I can tell you that I can tell you personal stories of lives who have been saved. We had a couple come in, their baby had IUFD, intrauterine fetal demise. They died in the uterus, and the couple refused an autopsy, but we saw that something was really wrong. and we were able to convince them to send the placenta, and we were able to diagnose a significant placental pathology. And when their second baby was born and had difficulty, we were prepared based on being able to encourage them to send the placenta in their previous birth. So 90% of these diagnoses are crucial to the families and to their futures and to their baby's health. And I think that especially when we're touching on topics like, I'm sure all of you here are nurses and midwives and are students and understand the significance, but when we're touching on topics like hypertension and preeclampsia, the significance that we now know, despite the fact that the placenta is completely understudied, and fields like preeclampsia, that the impact and significance of preeclampsia on people's lives for the future has not even begun to be studied. We're just starting now to study this. But if we have a woman who has preeclampsia and we send the placenta, we're able to see that there are vascular changes and damages, we can give her advice and follow up for the rest of her life that she might not necessarily have done had we not diagnosed these things postpartum. So to anyone here who doesn't understand this incredible organ, this placenta, which acts as lungs, kidney, immune system, the cardiovascular system in this one tiny circle of an organ, and doesn't appreciate you, I hope that this webinar opened your eyes to understand how important it is to consider sending that placenta for pathology, getting these things that we might not have been able to diagnose, and truly saving future lives. I'll let Olivia, my colleague, Dr. Olivia, speak a little bit about her thoughts, and thank you so much. And I'm here for any questions if anyone has.
Okay, thank you very much. I'm Olivia Baloyi, Dr. Baloyi, PhD. I'm from South Africa. I am a registered midwife specialist, but I'm working in a university. I would like to echo what my colleague has just said now. A placenta is a very important organ, you know, and most of the time it seems to be underestimated, undermined. We don't pay much attention to that. As the presenter was presenting, I was wondering, thinking to myself that, you know, coming from a low middle income country and having listened and knowing the importance of the placenta, it pains me in the fact that, like, for example, in South Africa, we have got very high litigations. And when the litigation comes, most of the time, the patients would win the case, you know, because when there's a payout, then it means the patient had a case. And when the case comes in, the placenta is gone long time ago. It's not there to be found. So we had to deal with, for example, the consequences of hypoxia, you know, which could have happened because of placental pathology. But now, because the placenta is not there, you know, we can't say, you know, this about the placenta. There was a study that was conducted in South Africa where they looked into 30 placentas of pregnancies where the newborns had complications of hypoxia, like your cerebral palsy and so forth. Out of the 30 placentas which were taken for pathology examination, only one placenta was normal. The 30 were abnormal. So now it raises, you know, questions as to how many of those did we miss, you know, by not sending a placenta for pathology, even when there is a need, even when the family is not, you know, raising any issues, but you as a midwife, you as a doctor, you have examined the placenta, or at least you knew that you were treating this patient with severe preeclampsia and so forth. I think it should be something that maybe is done where we anticipate issues, and not only where we anticipate issues in terms of litigations, but also just for it to be done so that we are well prepared for subsequent pregnancies. But like I'm saying, you know, coming from a low middle income country where healthcare services are free, you know, you can imagine the backlog of everything. So it wouldn't be possible to send all, of the placentas for pathology, but I do agree that it is important. So for me, my take-home message as an educator, I was also reflecting and asking myself, Olivia, as an educator, how deep do you teach your students examination of the placenta? Do I just focus on the basics? Do I teach them to identify any possible complications that can be identified from the placenta? So from now going forward, I told myself that despite the difficult terminology that comes with placenta, its examination and the pathology, because the terminology that is used with the placenta, if you go deeper, it's very difficult. But I'm gonna make sure that I teach my students that, because in South Africa, the midwives are the ones who are at the forefront. So with each delivery, we examine the placenta. But most of the time, you get the basics, placenta round, cord, centrally located, 3 blood vessels, and you never get, any other thing. But then you now wonder, there was a study that evidenced that out of the 30 placentas which were examined, 1 placenta was normal. And remember, those 30 placentas which were sent for pathology, some midwife somewhere examined that placenta. What did they record on examination of the placenta? I wouldn't be surprised if it was more of a normal examination, yet the pathology is saying something else. Thank you very much. That is my contribution. I don't know if there's anyone who wants to ask a question.
I think that I'll just summarize by saying that one of the things that there was a question that was posed to me privately about the significance about the cultural, what I touched about the cultural issues with regards to the placenta. And the person asked if I could expound a little bit more on the cultural issues, which I would gladly do. I think that especially when we're dealing with populations who aren't necessarily getting the healthcare or the education that they need specifically, or marginalized communities. So there's a lot of talk about when something goes wrong in a pregnancy, there's a lot of support for that family with regards to their child and their loss of their child and the impact of that on the rest of their lives. But a lot of these families are wary of the hospitals. They don't necessarily trust the hospital system, and they get concerned about sending the body off, or religious reasons they're not allowed to send the body off. And that creates this experience where we can see that something isn't right, but we can't put our finger on it. And we don't understand the implications for the future. And if we're able to talk to these families and talk to these, speak to them on a cultural level, which I think is the essence of the field of medicine and the essence of the field of birth as a physiological and / pathological field, is our ability to speak to them on that level and explain to them that the significance of this organ, which doesn't necessarily have the same religious significance in all religions, is a way that can give us so many answers without desecrating in their mind the sacredity of their child that has passed. And that is a message I think all of us as healthcare providers can get across to our patients. Explain to them that in our hands, we have this little tiny circle that can give us 90% of the answers that we're looking for, and don't discard that placenta. And another tip that I would give all to you is that keep the placenta in the room. If a patient comes and they have an IUFD and they're not ready to make these decisions yet, put the placenta in formaldehyde, keep it in a corner in a box, and take that time to sit with that family through their cultural needs, with the focus on their cultural perspective, and explain to them the significance of this one small test and the impact it can have on not just their future pregnancies, but their future lives for the mother and for their unborn children. So that would be my advice too, when you're dealing with specific cultural sensitivities across the globe, across all types of your patients from all populations and all walks. And thank you guys so much for coming.
Yes, thank you so much. And thank you, both of you, for your insights. I'm so glad you brought up the that study about birth trauma versus placental pathology, I'd totally forgotten that. And it was very eye-opening to realize that so many cases that had been ascribed to birth trauma were actually placental pathology. And I think it's just another great example of where the more we learn, I mean, it totally changes the way we think. And I think that's just a perfect example of it. And I hope we can continue to learn so we can answer even more questions like that in the future and find easier ways of answering those questions too. And thank you so much. And thank you so much to all of the participants. I only had one Q&A and I think I already answered that. So I guess we're all done for the morning, unless there's something else I don't know about. So I, again, want to thank the panelists profusely and thank Nursing Now for inviting a pathologist and letting a pathologist come and talk to you all today. It was truly an honor, and I really appreciated it a lot. So thank you.
Thank you, Dr. Dara.
Thank you, everybody.